I think so.
Okay. So I have no financial or non-financial relationships to disclose. Today, we will be looking at data across the 5 health regions in BC. So we have Fraser Health in dark blue, Vancouver Coastal Health in orange, Island Health in green, Interior Health in red, and Northern Health in light blue. So we're going to go over learning objectives and rationale, definitions and BC substance use data, addiction treatment and availability in BC, conclusions, implications for people living in semi-urban and rural communities in BC, implications and opportunities for social workers in BC, and then we'll have time for some questions. So my learning objectives are to gain an understanding of the evidence base behind the current addiction treatment options with a focus on psychosocial treatments, to gain an understanding of the availability of treatment options within BC and highlight the disparity between access to treatment in urban versus rural communities, and to gain an understanding of the implications for those living in semi-urban and rural communities and opportunities for social work practice. My interest in the topic of evidence-based addiction care, and particularly the disparity between access to evidence-based services in urban versus rural communities, stems from my work in the downtown east side, where I've had the opportunity to work with a concerning number of individuals who came from rural communities to seek treatment that was not available to them closer to home, and then either didn't make it to their destination, left early, or had difficulties returning home, resulting in their becoming stuck, for a lack of a better word, in the downtown east side. I want to be very clear that that complex and complicated as it may be, the downtown east side is a vibrant community, and I am in no way suggesting otherwise. However, for people who have come to the Lower Mainland for the purpose of seeking addiction treatment, becoming entrenched in the downtown east side, away from their home communities and families, can be quite detrimental to both the individual and those at home who love and miss them. Without starting out on too much of a depressing foot, I do want to acknowledge that the worsening and ongoing toxic drug supply crisis will claim the lives of approximately 7 members of our community here in BC today alone. To those individuals and their families, I want to say that you are seen, you are valued, and you are more than a statistic. Okay, so I'm going to go through some definitions for some of the terms that we're going to be using. So for the purpose of this presentation, we will define urban as in or within 25 kilometers of a city whose population is greater than 100,000. Examples include Vancouver, Kelowna, and Victoria. We will define semi-urban as in or within 25 kilometers of a town whose population is 25,000 to 100,000 people. Examples include Prince George, Penticton, and Parksville. We will define rural as a town of less than 25,000 and farther than 25 kilometers from a semi-urban or urban center. Examples include Atlin, Tofino, and Ashcroft. For the purposes of this presentation, addiction treatment will be used to encompass everything from harm reduction practices to bed-based treatment. We will be talking about many services that offer virtual options, which include both online via Zoom or a similar platform, or over the phone. Keep in mind that to access these services, the individual would need access to a phone, computer, or tablet, as well as reliable internet and/or telephone services. In this presentation, I will be using the term drug toxicity deaths in place of overdose deaths to reflect the evidence that people who use drugs are dying as a result of the toxic drug supply. This is in line with the language utilized in the BC Coroner's Report. In this presentation, I will be using the term overdose to describe the instances in which people experienced a drug toxicity event that would result in a death if a medical intervention had not occurred. These events are also sometimes known as drug poisonings. However, the term overdose reflects the language currently used by people who use drugs. So according to a report by the BC Ministry of Mental Health and Addictions, an estimated 202,000 people in BC have an alcohol use disorder, 101,000 have an opioid use disorder, and 26,000 have a stimulant use disorder, with populations that are marginalized and socially excluded identifying disproportionately higher rates of substance use and substance use related harms, as well as decreased access to addiction treatment options. According to a 2014 report from the BC Centre for Disease Control, using data from 2012, the highest rate of alcohol use at 13.31 liters per adult per year was in the northern geographic region of North Shore and Coast Garibaldi. The lowest rate at 4.51 liter per adult per year was in Richmond. As seen here, alcohol use is higher in the northern and eastern regions of BC compared to the rest of the province. This same report showed the prevalence of lifetime cannabis use in BC in 2011 as 44.3%, with the Kootenay boundary area having the highest prevalence of lifetime cannabis use at 62%, closely followed by Northern Interior at 61% and Northeast at 60%. There is no updated data that I could find on the prevalence of substances used in BC, which is why I'm using data from 2012. That's what was available. There is no data specific to opioid, stimulant, or benzodiazepine use prevalence in different areas within the province. However, this map details the rates of opioid agonist therapy prescribing within BC, which shows higher rates in some of the more remote areas. While this does not necessarily correlate to increased rates of opioid use disorder in those areas, when combined with the data on alcohol use and cannabis use, which are also increased in these areas, as well as data from a 2022 policy document by the BC Ministry of Mental Health and Addictions, which identifies that populations in BC that are the most marginalized and socially excluded reported disproportionately higher rates of substance use and substance use related harms, I think it's fair to assume that rates of substance use and substance use disorders are overall higher in rural communities in BC per capita. So for the purposes of this presentation, I will be looking at addiction care in three main categories: harm reduction, where we will look at supervised consumption sites and prescribed risk mitigation guidance; psychosocial treatments, where we will look at peer-led groups, community-based treatment, and bed-based treatment; and medical treatment, where we will look at medication-assisted therapy as a standalone treatment and detox as a standalone treatment. Using the National Harm Reduction Coalition's definition, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Two examples of harm reduction that we will be looking at today are prescribed risk mitigation guidance, or RMG, which include hydromorphone for opioid use disorder and dextroamphetamine for stimulant use disorder. For the purposes of this presentation, I will be focusing on hydromorphone RMG, given the very limited body of evidence supporting or refuting the efficacy of RMG for stimulant use disorder. Supervised consumption sites and overdose prevention sites both operate for the purpose of preventing overdoses and drug toxicity deaths. However, there is a legal difference between a supervised consumption site and an overdose prevention site. SCS are facilities that have been exempted by Health Canada under Section 56.1 of the Controlled Drugs and Substances Act and are typically staffed by healthcare professionals. OPS were established as a community-based response to overdose deaths and the sluggish bureaucracy associated with SCS applications. OPS tend to be peer-run, bare-bones facilities, sometimes consisting of a tent in a public park. So in British Columbia, risk mitigation guidance prescriptions of hydromorphone tablets were introduced during COVID-19 to reduce the risks of withdrawal and drug toxicity deaths in the context of greater isolation. However, RMG hydromorphone programs were already operating and being evaluated in Vancouver and Ontario. A 2023 study by Gagnon et al. Found that RMG can contribute to reducing injection-related health risks in addition to overdose risks. More specifically, they have the potential to address disease prevention and health promotion gaps that standalone downstream harm reduction interventions cannot address by working upstream and providing a safer alternative to fentanyl. The 2021 BC Coroner's Report stated that of the deaths attributed to drug poisoning and overdose between March 2020 and May 2021, there were no drug toxicity deaths attributed to hydromorphone alone based on toxicology screens. These findings resulted in the BC government releasing a policy direction statement advising all health authorities to provide access to a range of prescribed safer supply options to those at risk of drug toxicity related harms. RMG hydromorphone for opioid use disorder came into significant controversy when a 2022 rapid review of 19 studies by Monaruzaman et al., commissioned by the Alberta Ministry of Health for the legislature's Select Special Committee to examine safer supply, and published by the Simon Fraser University Centre for Applied Research in Mental Health and Addiction, found no evidence of benefits from RMG. This review was widely circulated, resulting in increasing public and political concerns regarding RMG hydromorphone. A letter to the committee was signed by 58 clinicians and research scientists expressing significant concerns regarding the review, identifying that it did not adhere to best standards for evidence reviews, and that an assessment of the report conducted by experts in reviewing methodologies at the BC Centre on Substance Use used the well-established AmStar tool and found the report to be of critically low quality. This letter strongly cautioned against using this review as a basis for policy, given its mischaracterization of its authors as experts in the field of addiction and misrepresentation of evidence. While there have been multiple smaller scale studies and reviews demonstrating the efficacy of RMG, a landmark study by Slonwat et al. Was published last week on January 11th, encompassing 5,882 participants who received prescribed RMG stimulants and or opioids from March 2020 to August 2021. This study found that the cohort prescribed RMG opioids had a 61% lower risk of death from any cause in the subsequent week, and were 55% less likely to die from drug toxicity in the subsequent week compared to the cohort not prescribed RMG opioids. It also showed a positive relationship between decreased mortality and number of days RMG was prescribed and accessed, finding that people who received prescribed RMG opioids for 4 or more days were 91% less likely to die from any causes and 88% less likely to die from drug toxicity in the subsequent week. While there is a difference, the difference between the OPS model and the SCS model is important with regard to availability in BC, for the purposes of the research, these two terms will be used interchangeably, as there was no obvious difference found between the two in the evidence base. 2023 study by Young et al. In Alberta showed an overall decrease in death from overdose and emergency department visits related to overdose after the opening of supervised consumption sites. From January 2017 through September 2023, this data was also reflected in BC, where there were more than 4.3 million visits to overdose prevention sites, 26,948 overdoses responded to, and only 1 death. A 2021 narrative study of 27 participants by Udshorn et al. Identified participant reports that accessing a supervised consumption site improved their lives beyond their engagement in the site itself, and the caring relationships with SCS staff led to an improved sense of self among participants. Udshorn et al. Posit that these relationships are an intervention in and of themselves that lead to quantifiable positive changes in the lives of participants. There is a lack of research on the implications for people in rural communities with regard to availability of services. However, as we will discuss, the rates of drug toxicity deaths are much higher in rural communities in BC, which would indicate that the implications are significant. Safer supply medication is prescribed at the discretion of the patient's doctor. There has been significant anecdotal evidence from patients who report being abruptly cut off their previously prescribed RMG hydromorphone within the last 6 months. So this is where the difference between OPS and SCS becomes key, as it is difficult to map the availability of overdose prevention sites outside of the Lower Mainland, where they are quite ubiquitous, as overdose prevention sites are run by nonprofits rather than the health authority. But here we can see where the health authority run supervised consumption sites are within BC. Peer-led groups are facilitated by people with lived and living experience with substance use and the specific program they are facilitating. In this presentation, we will be looking at the two main groups seen in the literature. The first being the 12-step model, which was first developed and implemented by the founders of Alcoholics Anonymous, Bill Wilson and Dr. Robert Holbrook Smith in 1935. It focuses on 12 steps to recovery, with the first step being to admit that you are powerless over alcohol, that your life has become unmanageable, and that you have come to believe that a power greater than yourself can restore you to sanity. 12-step meetings involve attendees self-identifying as alcoholics or addicts and sharing testimony of their experience with addiction and, if applicable, recovery. Self-management and recovery training, or SMART Recovery, was founded in 1994 to meet the increasing demand of health professionals and their patients for a secular and science-based alternative to 12-step programs. It draws on counseling modalities such as cognitive behavioral therapy, motivational enhancement therapy, rational emotive behavior therapy, and motivational interviewing, emphasizing a 4-point program to recovery: building motivation, coping with urges, problem solving, and lifestyle balance. While for the purposes of this presentation, we'll be primarily looking at the role of peers in peer-led groups, I want to highlight that peer specialists play a vital role throughout the spectrum of addiction care, and as anyone working in the field of addiction can attest, we could not do our jobs without them. And the impact they have on their clients, communities, and colleagues is absolutely invaluable. Talking to you too. So what does the research say about 12-step? Significant qualitative research on AA has presented the experiences of members who have embraced this identity and have been wholly praising of AA. Other theorists, however, have been strongly critical of the organization, often arguing that it emulates a cult. A 2023 study by Glassman et al. Sought to provide data towards reconciling the competing bodies of research. They found that AA was effective in supporting abstinence and improving the mental health for most participants, however, identified concerns that AA membership impacted the capacity of members to think critically about the AA model and cultivate independence and individualization. A 2020 Cochrane review by Kelly et al. Demonstrated that 12-step programs improve the rates of continuous abstinence at the 12, 24, and 36-month mark over other clinical interventions. It showed that participants in 12-step programs have a similar percentage of days abstinent at the 12-month mark compared to other clinical interventions, and a higher percentage of days abstinent at the 24 and 36-month mark. So there is a limited evidence base for SMART Recovery. A 2017 systematic review by Beck et al. Identified only 12 studies done on SMART Recovery, and that while the results were positive overall, they recommended greater utilization of validated data collection methods and performance-based trials. Participant feedback tends to be positive, as indicated in a 2022 study by Beck et al., which found a high level of participant satisfaction with online SMART Recovery groups and reported it contributed to their recovery. A longitudinal study by Zemmour et al., published in 2017, identified that participants who identified SMART Recovery as their primary group showed significantly lower odds of abstinence. However, it should be noted that abstinence is not always the individual's goal, and SMART Recovery is an individualized program. So what does it say about the comparison? There is limited data with only one longitudinal study to date. The Zemmour et al. Study was the first longitudinal comparative survey study of 12-step programs with major alternatives, including SMART Recovery, publishing findings from the first wave in 2016. The Peer Alternatives in Addiction, or PAL study, showed many differences across members of different groups and suggested higher satisfaction and cohesion among members of non-12-step groups, however, demonstrated higher efficacy for 12-step group members in abstinence. The completed PAL study, published by Zemmour in 2017, showed similar efficacy between 12-step programs and SMART Recovery when controlling for baseline recovery goals. This study was cited by the National Institute of Alcohol Abuse and Alcoholism when they published their 2022 recommendations for evidence-based treatment options, citing the importance of providing a range of treatment options, as no single treatment approach is universally successful or appropriate for all individuals. So as with harm reduction, there is a lack of research on the implications for people in rural communities with regard to availability of services. Here we can see in-person meetings for 12-step programs are widely available throughout southern BC, becoming increasingly sparse in central BC, with only 3 towns offering in-person meetings in the northern third of the province. Virtual meetings are available 7 days a week. For SMART Recovery, in-person meetings are available in some urban areas in southern and central BC, but no in-person meetings are available north of Terrace. There are virtual meetings available 7 days a week. The United Nations Office on Drugs and Crime defines community-based treatment as referring to a specific integrated model of treatment for people affected by drug use and dependence in the community, which provides a continuum of care from outreach and low-threshold services through detoxification and stabilization to aftercare and integration, including maintenance pharmacotherapy. While community-based treatment encompasses a variety of supports, for the purpose of this presentation, we will be focusing on clinician-led or on individual counseling, clinician-led groups, and recovery houses. As we will see, the majority of the evidence base for community-based treatment is from the 1990s to mid-2010s. However, I felt it was important to include this as it demonstrates that the efficacy of treatment and need for options is not new information, yet these services continue to be unavailable to many who need them. A 1990 article in the Drug and Alcohol Review by Saunders and Wilkinson highlights that motivation should be viewed from a cost-benefit analysis framework rather than as a static quality. They identify that confrontational approaches to addiction treatment increase resistance while including motivation increases success. This is further highlighted in a 2020 article by E.J. Katzien in the Journal of Addiction Treatment. Katzien demonstrates that depending on the particular emotional pain experienced by a person who uses substances, they discover a preference for a particular class of drug, which is linked to how individuals discover these specific effects in relation to the suffering associated with their self-regulation challenges. Katzien stresses the importance of appreciating these specificities as well as the therapeutic elements and attitudes utilized by clinicians, such as being more interactive and incorporating attitudes of kindness, support, empathy, respect, patience, and instruction in order to build and maintain a strong therapeutic alliance. In a 2017 article, Mick Devine lays out substance use disorders as a chronic health condition, explaining the relationship between substance use disorders and the brain, in particular the reward center. Based on this, Devine highlights the importance of counseling as a path to recovery, as the insight needed to manage a chronic health condition is often not a realistic expectation for people with substance use disorders to develop on their own. A 2006 article in the Journal of Clinical Psychology by Haga et al. Highlights the importance that people with substance use disorders be treated by specialized clinicians. Citing a 2003 journal article by Moose in Psychology of Addictive Behavior, Haga et al. Summarize that clients treated by addiction specialists and mental health clinicians typically have more success than do clients treated by primary care providers only. So there is a limited research pool when it comes to clinician-led groups. A 2017 article in the Journal of Groups in Addiction Recovery by Went and Gone highlights that despite the clinical predominance and anecdotal effectiveness of group programs for people with substance use disorders, the majority of the research has focused on individual therapy, which has been adapted for a group format. As identified in his chapter of the 2008 book, Group Psychotherapy and Addiction, edited by Reading and Wegman, Philip Flores indicates that there is an inverse relationship between addiction and healthy interpersonal attachments, and that the deeper into addiction someone slides, the more vulnerable they become to their substance becoming an increasing obstacle to, but also substitute for, interpersonal relationships. Flores goes on to highlight that by providing addiction treatment in a group format, participants are able to learn how to develop healthy attachments to one another in a safe, supported, and facilitated environment. In their 2013 book, Substance Abuse Treatment and Stages of Change, Connors et al. Indicate that a number of studies suggest group treatment can be as effective or more effective than individual treatment, and almost all major schools of individual psychotherapy have been adapted for groups. A 2004 review of 24 treatment outcome studies by Weiss et al. Showed that adding specialized group therapy to an individual's current treatment can improve outcomes, and that treatment outcomes in the studies reviewed were virtually identical between individual and groups, with no particular type of group therapy emerging as superior to another. Excuse me. A 2012 review of 2 studies looking at participants living in Oxford House recovery homes by Jason et al. Demonstrated that developing a single connection within an Oxford house reduced the probability of relapse in the first 6 months by a factor of 5. These findings supported a 2011 longitudinal study of 300 residents of recovery houses over 18 months by Polkin et al., which documented improvements in substance use, employment, arrests, and psychiatric symptoms. Not all recovery houses are created equal, however. A 2019 analysis by Miracle et al. Of 330 residents from 49 recovery houses demonstrated that recovery houses overall contribute to improved outcomes for residents in the area of substance use, employment, and interactions with the criminal justice system. However, the structure of the recovery house is a key factor. Within BC, the terms recovery house, sober living house, and halfway house are not protected, nor are they governed by the BC Residential Tenancy Act, which has resulted in the ability for places identifying as recovery houses to create incredibly unsafe environments that take advantage of the vulnerabilities of people with substance use disorders. As reported by news outlets such as the CBC and the Vancouver Sun on multiple occasions over the last 15 years, ongoing reports of sexual and financial abuse, as well as rampant drug use in unregulated recovery houses, have been reported by residents throughout the province. A 2023 study by Islam et al. Highlighted the importance of finding ways to enhance aspects of social support for those in recovery from substance use disorders, identifying a positive correlation between higher levels of social support and decreased substance use with higher rates of abstinence. Islam et al. Go on to stress the importance of social supports who are also abstinent, if abstinence is the individual's goal, citing higher abstinence rates in individuals whose social circles support abstinence and lower abstinence rates in those whose social circles use substances. People who use substances are at a higher risk of homelessness, and people who are homeless are at a higher risk of substance use disorders, creating a vicious cycle for many. This is highlighted in the findings from a 2019 qualitative study of 28 residents of recovery houses who were on parole or probation by de Guzman et al. De Guzman et al. Note that study participants identified housing as critically important after incarceration, and that those who were nearing the end of their stay at the house had significant concerns regarding where they would go afterwards and the impact that being homeless would have on their sobriety. So as with harm reduction and peer-led groups, there is a lack of research on the implication for people who live in rural communities with regards to availability of services. Here we can see the availability of funded individual counseling within the health authorities. Here we can see the availability of clinician-led groups. And given the reports surrounding unlicensed recovery houses within BC, I will focus on recovery houses which are vetted and registered with the BC CSU, as we can see here. Bed-based treatment, sometimes known colloquially as rehab, refers to intensive addiction treatment that is offered at a live-in center. Stays typically last for a minimum of 3 months to a maximum of 12, with many centers offering second stage housing following the completion of their treatment program. So what does the research say? Overall, evidence is moderate. A 2014 review by Reif et al. Reported that overall, the findings were in favor of bed-based treatment for some populations, with studies showing better or equivalent outcomes between bed-based and other forms of treatment. Reif et al. Highlighted, however, a need for further study to determine which demographics of people bed-based treatment is likely to be most effective for. In a perfect world, a 1995 study by McKay et al. On the efficacy of bed-based treatment versus intensive outpatient day treatment for men with alcohol use disorder noted no differences in outcomes between those who participated in bed-based treatment versus day treatment. This landmark study has informed policymakers when weighing the cost benefit of bed-based versus outpatient treatment. However, it is important to remember that one of the exclusion criteria for this study was unstable residents. They found that previous inconsistencies in data between bed-based and intensive outpatient treatment could be explained in part by including their exclusion criteria, which highlights the need for additional social supports with unstable or no housing. Similar findings were presented by Wintbrot et al. In their 2007 study comparing overall treatment outcomes from day hospital treatment and bed-based treatment, however, did not mention housing in either their exclusion criteria or their results. A 2002 review by Zerger found that dropout rates for homeless participants in community-based programs were significantly and consistently higher than bed-based programs, highlighting the consistent theme of the importance of housing in successfully treating individuals with substance use disorders and concomitant homelessness. This is supported by a 2005 study of 196 participants with stimulant use disorder receiving community-based treatment this is supported by a 2005 study of 196 participants with stimulant use disorder and concomitant homelessness who are receiving community-based treatment by Milby et al., which showed that those who received abstinence-based housing along with day treatment had the highest prevalence of abstinence, followed by those who provided with non-abstinence-based housing, followed by those with no housing. As with harm reduction, peer-led groups, and community-based groups, there is a lack of research done on the implications for people in rural communities of these services not being widely available. There are a total of 3,201 publicly funded treatment beds in BC, which, as we can see, are all quite centralized. While exceptions are made, bed-based treatment centers are typically accessible primarily to individuals living in that health authority. For Indigenous and Métis folks in BC, there are 10 bed-based treatment programs run by First Nations Health Authority, 4 of which are in northern BC, where there are no health authority-run bed-based treatment programs. So as I am not a physician and medication is well outside my scope of practice, I will not be looking at the evidence supporting different medications. Instead, I will be presenting the evidence base for medication for medication-assisted therapy as a standalone treatment versus in conjunction with psychosocial treatments. A 1997 study of 100 people with opioid use disorder and concomitant cocaine disorder by Kraft et al. Broke the group into 3 cohorts. Over the 6-month trial, all patients received 60 to 90 milligrams of methadone, with group 1 receiving no psychosocial supports, group 2 receiving 3 times weekly drug counseling, and group 3 receiving daily counseling, family therapy, and social work support. The study found that after 1 year, 29% of group 1, 47% of group 2, and 49% of group 3 remained abstinent. A 2022 meta-analytic review by Strelo found that medication-assisted therapy for people with opioid use disorder had a direct influence on overall wellness, however, highlighted a need to combine this with cognitive behavioral therapy, which was demonstrated to improve both medication adherence and overall outcomes. This was also highlighted in a 2021 published dissertation by Barry, which found that counseling appointments were positively associated with retention on buprenorphine at the 3-month mark. A 2015 review by Smith-Connery highlights that the benefits of extended methadone or buprenorphine naloxone maintenance delivered with an opioid treatment program, which required daily medication monitoring during early recovery and provided structured psychosocial interventions and integrated care options, are especially pronounced for populations with significant drug-related legal charges and drug-using social networks, for people with co-occurring medical illnesses related to injection drug use, and for socially disadvantaged patients who may receive, through the integrated structure of the program, the intensive social and medical services needed to support sustained recovery. So here we can see the prevalence of OAT prescribing within BC. And here we can see that despite the evidence indicating the importance of psychosocial treatments in conjunction with medication-assisted therapy, the vast majority of psychosocial treatment options are centralized to areas of the province that have overall lower OAT prescribing. It should be noted that the rates of OAT prescribing are by population size rather than the number of prescriptions written, which makes comparing this to number of psychosocial treatments available not entirely reliable. However, it aids the overall picture of limited supports in rural and semi-urban communities despite high needs. The BCCSU has defined acute withdrawal management, also known as detox, as an intervention aimed at reducing health harms, such as withdrawal seizures associated with substance use cessation. The BCCSU notes, however, as a standalone intervention, withdrawal management does not constitute addiction treatment and can be associated with harm, especially in the context of opioid use disorders. A 2020 analysis of 30,681 patients with opioid use disorder who completed detox at least once, for a total of 61,819 detox episodes between 2012 and 2014 by Wally et al., found substantially reduced mortality rates across the cohort in those who received medication-assisted therapy and/or accessed bed-based treatment following detox. Wally et al. Concluded that patients should not simply be detoxed, but should be titrated onto an opioid therapy that they are likely to continue and connected with bed-based treatment, with evidence showing that the combination of both is particularly effective. In the large-scale longitudinal research evaluation project by Sells and Simpson on the effectiveness of different drug treatments, encompassing almost 44,000 participants and 52 treatment centers in the US and Puerto Rico from June 1969 to March 1973, researchers found that 29.5% of participants who received methadone, 36.9% of participants who went to bed-based treatment, and 34.4% of participants who went to community-based treatment were abstinent from illicit drugs and demonstrated generally positive outcomes for the first 3 years following the program. While this was only found in 19.6% of participants who completed detox only, and 21% of those who completed an intake, but nothing further. These results are supported by a 2018 longitudinal analysis of post-detox outcomes in people with opioid use disorder by Ivers et al. This analysis indicated that participants who did not access post-detox treatment had significantly shorter periods of abstinence following detox than those who accessed treatment. So here we can see the availability of detox facilities within BC and the various health authorities. So where does that leave us? The research demonstrates that there are a variety of evidence-based psychosocial treatments for people with substance use disorders, and that these treatments save lives, reduce harm to the individual as well as their families and communities, and offer a path to recovery to those for whom decreasing use or abstinence is their goal. The research demonstrates the need to meet people where they are both physically and where they're at both physically and with regard to their stage of change, which requires that a range of addiction supports be widely available. The evidence shows that medical detox without immediate psychosocial treatment does not promote long-term abstinence. This is particularly relevant to people who use opioids or who are at risk of using a contaminated supply, as even a short period of abstinence from opioids can drastically change someone's tolerance, putting them at increased risk of death from overdose. However, there is a paucity of supports available in rural communities, as well as a lack of research on the implications for those communities. So there is little to no research on rural environments. However, as highlighted in a 2020 article by Ibragimov et al., despite the risk environment model, or REM, being widely used to understand the determinants of drug-related harms in specific environments and demographics, this model has not been applied to rural communities in any of the research found. Despite rural areas across the world sharing many REM features that may shape vulnerability to drug-related harms and influence the provision of evidence-based services, including physical isolation, underdeveloped infrastructure and healthcare systems, stigma against people who use drugs, and limited economic opportunities, REM-guided research about how these features intersect over time to shape drug-related harms remains limited. There is a body of research, however, on the impact of politics and social conditions on harm reduction practices, which I would argue are exacerbated in rural communities, given that these communities tend to be much more politically and socially conservative. A 2019 paper by Strike and Watson in the International Journal of Drug Policy highlights that harm reduction practices are life-saving, but require a political environment at all levels of government that act from a harm reduction lens and take into account the complex biopsychosocial factors related to substance use. A 2020 paper by Goldenberg et al. Showed that in a multivariate confounder model, there was a direct correlation between exposure to police-related barriers to harm reduction strategies and higher odds of non-fatal overdose. A 2021 America-wide study by Socia et al. Found that people were more likely to be in support of an overdose prevention site than a safe consumption site, even though the services provided at the two sites are virtually identical, highlighting the importance of using language that will appeal to the public when introducing harm reduction strategies. So what are the implications for people in rural communities in BC seeking psychosocial treatments? Oops, sorry. While research specific to this question is limited, looking at the evidence for psychosocial treatments, availability of services within BC, and recent statistics, I would posit several implications. First and foremost, that people living in rural communities, in rural or otherwise marginalized communities, face greater barriers to accessing care as a direct result of their social and geographic location. While individual counseling, clinician-led groups, and peer-led groups have become more widely available through virtual services, this requires individuals to have access to a phone, tablet, or laptop, a certain level of tech literacy, and reliable internet or telephone services. For those who do not have addiction treatment options available in their home communities, a 2020, I'm very sorry, I'm going to go back just a little bit. Firstly, that people living in rural communities or in rural or otherwise marginalized communities face greater barriers to accessing care as a direct result of their social and geographic location. A 2021 study of people who use drugs in rural North Carolina by Lawton et al. Identified the top cited barriers accessing treatment was the lack of resources to deliver treatment. This finding was supported in a 2022 review by Davis and O'Neill of 24 studies conducted between 2017 and 2022, which found that globally, people living in rural and remote areas were less likely to receive care for alcohol-related concerns compared to those residing in urban areas. That rural areas suffered from insufficient access to specialty providers, and that rural residents were more likely to experience greater stigma regarding seeking treatment for alcohol-related concerns. This prompted Davis and O'Neill to recommend using innovative and widely accessible treatment approaches, facilitating cooperation and engagement among stakeholders, including primary care doctors, emergency departments, mental health care workers, and religious leaders, and addressing stigma among rural residents by providing education to community members. So there are limited options for people in rural communities with regards to accessing treatment. While individual counseling and clinician-led groups and peer-led groups have become more widely available through virtual services, this requires individuals to have access to a phone, tablet, or laptop, a certain level of tech literacy, and reliable internet and/or telephone services. For those who do not have addiction treatment options available in their home community and for whom virtual services are not a reasonable or preferred option, they are left with the choice of not accessing treatment or traveling outside of their home communities for treatment, which presents its own set of challenges, from coordinating travel plans to housing in order to access harm reduction or community-based services to support in applying to bed-based treatment. The final option that people are faced with is not accessing treatment at all. A 2022 policy document by the BC Ministry of Mental Health and Addictions identifies that populations in BC that are the most marginalized and socially excluded reported disproportionately high rates of substance use and substance use-related harms. It goes on to highlight that in the current system, services are often inaccessible due to lack of capacity, access barriers, cost, or the absence of appropriate supports to meet people's diverse needs, and that these barriers disproportionately impact people living in rural and remote communities. As we've discussed, there is very limited, if any, data on the implications of the disparity in addiction treatment between urban and rural settings for people in rural communities. However, given the statistics around drug toxicity deaths in BC, we can infer that the lack of evidence-based addiction treatment in higher risk communities is killing people. As you can see, in 2015, 1 year before the toxic drug supply crisis was declared a public health emergency, drug toxicity deaths were more common in urban areas in BC. This has changed drastically over the last 8 years. And with the exception of Vancouver, which continues to see extremely high rates of drug toxicity deaths, the highest rates of deaths are occurring in rural areas in BC. A 2022 study by Hu et al. Reviewed the trends of drug toxicity deaths in British Columbia from 2015 to 2018. Researchers found that the odds of drug toxicity deaths were about 30% higher in rural areas than in large urban centers, with some regions reporting odds 50% higher than others. This study showed an overall increasing trend in drug toxicity deaths across the province. However, the increase occurred earlier and faster in the interior and northern health regions. Coming back to our map of BC, we can see here that despite the rates of drug toxicity deaths being significantly higher in northern and central BC, the vast majority of psychosocial treatment options are centralized to the bottom quarter of the province. As with the prevalence of OAT prescribing, it should be noted that the rates of drug toxicity deaths are by population size rather than the individual deaths, which makes comparing this to the number of psychosocial treatments available not entirely reliable. However, it gives us an idea of where the highest needs are versus where the supports are. So what do we do about it? Social workers are uniquely situated to be able to not only advocate for change at a micro, meso, and macro level, but also be part of that change in frontline practice. We know from the research that psychosocial treatments are a necessary part of addiction care, and that this care is not available to many of the most vulnerable members of our community due to their geographic location. It is therefore our responsibility to continue advocating for evidence-based practices within healthcare, which in the case of addiction care involves decentralizing treatment and ensuring equitable access to care for all communities. By building capacity in rural health services settings to provide community-based addiction care, whether it be peer-led or clinician-led, would not only serve to increase access to addiction care throughout BC, but may also be an important part in decreasing the stigma associated with substance use disorders were it to become a typical service offered in any given healthcare setting. While there is a good body of research on the lack of addiction care in rural communities throughout North America, there is very limited data on what this means at an individual level for people who leave their home communities to seek addiction treatment elsewhere, and the successes and challenges this presents for them as well as their loved ones at home. Further research into this would no doubt add to our collective ability to advocate for change, as it will give us specific examples of how the disparity in access is impacting people. And with that, I want to give special thanks to Jessica Mensinger and Zan Rothenberg for all of their support and guidance, as well as the Health Sciences Association for funding my fellowship this year. Does anyone have any questions? Any questions?
Thank you, Kat. As always, I'm so impressed with the scope of your What's New, because I think you took on like 5 different What's New topics inside of that. So thank you. I mean, are there any questions from the room? I have a few questions if nobody has questions here, but I'd like to hear if there are any questions in the room. Yeah.
Hey, Kat, good job. Do you think that there's not enough, like, you know how like recovery houses and recovery beds, it's a lot of nonprofits, right?
Yeah.
It's a lot of kind of just people flying by the seat of their pants and stuff, and that we don't have quite enough centralized or decentralized, I guess, from like health authorities, treatment options, and that we're not getting it out, and that it's kind of a little bit too patchworky, and that's one of the big reasons why we're not having as much.
I think that's part of it, and I think when we contract out services, the more different organizations that we contract out services to, the harder it is to maintain standards of care, which I think we're seeing in the recovery house realm. So I definitely think that's part of it. I don't necessarily have an answer for how to fix that other than more funding for healthcare or health authority run programs. Yeah.
Sorry, just trying to scroll
I have
through
a
this.
question.
Yes.
Yeah.
Yes.
Thanks, Kat. That was really good. One thing that I'm thinking about is like how we often have people come to us and like they want to go to detox and then they kind of don't want to do anything else after that. Like they think they can kind of fly by the seat of their pants, which as we can see, like empirically, we know that's can be really harmful. So like, how do you suggest we like redirect people away from that model? Like we want to be patient-centered and help people get into detox. Like they see that as the gold standard and the first step, but then we don't have the other services to line up. So how do we sort of redirect or support people through that like ambiguity? That's something I'm really struggling with.
That's a great question. And I also struggle with that. I think it would be important to separate the medical detox from having somewhere to stay. And I know that we see a lot of people who are asking for detox because they just want somewhere to sleep for 3 days, which is reasonable. And also not what detox is for. So I think that goes back to just there needing to be a broader range of supports for people. So supports for people who don't necessarily want to reduce or stop their substance use, but would like somewhere safe to sleep at night, which is an extremely reasonable and reasonable, I don't have another word for it. It is a reasonable thing to need and to ask for. For people who are really committed to decreasing or stopping their substance use, but don't feel that treatment afterwards is going to be effective, I think just sort of having a conversation with them about, okay, so what has worked for you in the past? What hasn't worked? How is this time going to be different? And really getting a sense of what it is that is they're feeling the barrier for them going to bed-based treatment, and then seeing if they would be open to some community-based supports. But yeah, it is. I don't have a sort of a magic answer for that. I also struggle with it all the time. And I think what it really comes back to is that our system is not equipped to meet the quantity of need that exists. Thanks.
And lack of housing.
And lack of housing.
And lack of
Mark.
housing, yeah.
What a statement. I'm just wondering, like, because I know, like, the recovery houses, they were taking clients for a period of time.
Yeah.
Now they are. They have their license, right? But I just wonder about, like, for some people who are really trying to be abstinence, I get that can be challenging. And I just wonder, do we, like, work at Rakish, do we actually talk about the old school, like, train spotting, like, just like bite the bullet? Like, I know a lot of my friends have done that, like,
Yeah.
old school, right? But it's just like, you seem to like, just want to give them like the treat, right? I seem like, I'd like to know how many people, like, we're increasing the dosages.
Yeah.
And I just wonder what the figures would be, like, decreasing the dosages.
That is a great question. And I think that definitely is more of a physician than a social work question. Karen might have an idea.
I'm actually maybe interested because, like, he's talking about old school, so like us, but back in our day, we didn't have that.
Yeah, that.
So the drugs now
Yeah.
are a lot more toxic than the drugs that we were using. So it's a lot
Yeah.
easier back then to get off the drugs than it is now.
Yeah. Claire.
Because I am a prescriber and I don't, I'm not saying that, but anecdotally, we've definitely found as a prescriber, it's much more difficult. This is what my clients reported to me, that even though they're on higher and higher doses of oat, they're not feeling like their symptoms are controlled. And that, I think, speaks to what you're mentioning about, like, there's a lot more toxicity within the supply. So we're not totally sure what they're withdrawing from it. So it has been actually really helpful, even though I know there's some question about how often you use it, but actually I use it with some clients just so that we can figure out what's in their system, because so many things are coming up. And that's been, and I found that really affected my oat prescribing, because people are saying, I'm not getting, my symptoms are not controlled. And then trying to figure out what that is, because just increasing oat isn't necessarily working.
But I also noticed that people that, that I know some people that for years have been off heroin and they're on methadone, and it's like, they're so tied to that methadone. Like, it's all up here. Like I was an opioid user myself, so I think that fear of being sick, right? It's just, it's such a fear, right? And I know I've seen people how sick they can get, right? But it's like, you can get over it, right? Like, if it was meant to be supervised, right? Like, and I just think that there's still change, right?
And I think then it just,
I mean, suffocate, but it just seems like you're still like, with that fear. of, like, not doing it or getting off it.
and I think it just comes down to the sort of individual cost benefit analysis of, is it worth it to stay on methadone for your whole life, knowing that it does limit you, or is that worth not completely going off it and feeling sick and having those cravings come back and the fear that is then going to trigger a relapse? Or is the sort of negative aspects of being on methadone worth trying a detox? And I think the point that I'm trying to make is that addiction care needs to be individualized, and there is no one size fits all model. And so when it comes to psychosocial treatments, if there's only one psychosocial treatment available in 100-kilometer radius from where you live, and that's not a treatment that fits for you, then it might as well not exist. That it needs to be individualized, and all of the data shows we need options. I'm just mindful of time.
And I know there's a few questions that are online, so maybe we can just send those directly to you.
Sure.
Those to you, and
Sure.
we can get those questions answered. And
then I just wanted to just go through a couple of my references.
And I think there were questions about getting a hold of your slides and references. And
if anybody wants to give me feedback, I would really, really appreciate it. Positive, constructive, you're the worst. Any and all of the above would be really appreciated. And then yes, I can
we'll make
just
sure,
send them to me. Yeah.